Good morning, everybody. At the outset, I would like to thank Purendra for making me part of his course. The topic of managing cataract post-keratoplasty. The cataract which occurs post-keratoplasty can be a natural progression of the lenticular changes. It can be secondary to intraoperative trauma during penetrating keratoplasty because of manipulation with the instruments, or post-operatively it can be either induced secondary to inflammation or with the prolonged use of topical steroids. So what do we look for when we do cataract post-keratoplasty? I think the timing of cataract surgery is guided by the extent of lenticular changes. Obviously, when you do a keratoplasty and if your patient has a cataract, you don't want to immediately go in and do your cataract surgery. You want to wait till the wound healing of the graft is complete. Ideally, you would want to do all the suture removal and wait for a stable corneal surface. At least topography done 3 months apart should show a stable topography. And if you do have astigmatism, this can be either regular or irregular. This has to be managed prior to managing cataract. You can do astigmatic keratotomy, which can be either manual or femtosecond laser assisted, especially if the astigmatism is pretty large. Or you can resort to doing a topography guided laser treatment to try and make the surface more regular. And with the presence of astigmatism up to, for the normal toric lenses up to 4 to 5 diopters, you can use the conventional toric IOLs. Beyond that, you can even customize toric IOLs with regular astigmatism for the cataract surgery. Now, this is a patient where patient had astigmatism almost up to 10 diopters. So we use the femtosecond laser to make paired arcuate incisions just inside the graft-host junction. And you can see that after using the femtosecond laser, the paired cuts, which were for 1 clock hour, we are at 90% depth. We are just using the Sinskey hook to open up the cuts which have been made. And that's the post-op appearance of the patient. And that's the topography. You can see that the astigmatism was pretty large, almost 10 diopters. And after using the femtosecond laser-assisted arcuate keratotomy, we were able to bring it down to something like 6.5 diopters. And after that, the patient successfully underwent a toric IOL. The other thing you can do is, like in this patient, the pre-op cylinder was almost about 7, and the patient had very early cataract. So before going and doing a cataract surgery, we decided to do a topography-guided laser ablation, surface ablation, and you can see that we brought down his astigmatism to about 2.5 diopters. He was very happy, and later on, as the cataract progresses, and if we have to do, we can manage this with a standard toric IOL. When you do surgery, I think you have to understand that post-keratoplasty, the cornea is a neurotrophic cornea because all the corneal nerve endings have been cut at the graft-host junction. Visualization is also an issue. You have to see how clear your graft is. You have to protect the epithelium, and you have to minimize the surface toxicity. So avoid using a lot of topical medications because a lot of these anesthetic drops or the topical dilating drops, they all contain benzalkonium chloride, so don't use them very frequently. During surgery, prevent desiccation of the surface and have your nurse keep the surface moist with a balanced salt solution. I usually like to put methyl cellulose on the surface, which keeps my surface moist. Go in for smaller incisions, and if you have astigmatism, sometimes you can combine this with limbal relaxing incision to manage astigmatism up to 1.5 diopters, especially if you're not using a toric IOL. The second thing that you have is endothelial protection. So if you look at, this is typically what your specular will show when you see a patient several years down the lane following a keratoplasty. The cell counts would be in the range of about, somewhere 1,000, 1,200, sometimes even below that. But what is surprising is that despite having a low cell count, if you look at the corneal thickness, if you see in this case, the thickness is about 505 microns. So despite having low cell counts, the corneal thickness is maintained, and that's because these are healthy endothelial cells. These are not like fuchs or where the endothelium is abnormal, and as you have a decrease in endothelial cell count, correspondingly your pachymetry also increases. During surgery, use dispersive viscoelastic to protect the endothelium, minimal phaco energy, and maintain a deep anterior chamber. So even if you have to repeatedly inject some viscoelastic to maintain the depth of the chamber, I think it's important that you do that rather than trying to complete the phaco surgery in one go, and because you're working with a compromised cornea here. And avoid waiting for the cataract to become very hard. So a lot of times when we see cataract post-keratoplasty, we advise the patient not to wait too long, because if they wait too long and if you have a very hard cataract, then sometimes doing a phaco in such a situation may be a bit challenging. And for me, if I see patients like that, and if I see that it's a very hard cataract, maybe I'll resort to doing either an extracapsular cataract surgery or an SICS rather than doing a phacoemulsification. Just to show you one of these cases, this is again a post-keratoplasty. The surface is stable, has astigmatism. We are planning on a toric IOL, so we do mark the surface, mark the axis of the toric IOL alignment, and you can see it's mostly a posterior subcapsular cataract arising from possibly the steroid therapy that's been given over time. We put some methyl cellulose on the surface to protect the epithelium. Use viscoelastic, dispersive, and cohesive both. We use, you can use either something like Viscoat and sodium hyaluronate. Doing the capsular excess, if your view is very good, it's fine. If not, I think you can resort to staining the anterior capsule using trypan blue. That can help. Otherwise, because if the corneal graft epithelium is not very clear, then while doing the capsular excess, you might lose the edge, and that's not something that you that desirable. So in this case, we had a very good red reflex, so we were able to complete our capsular excess. In terms of incision, in this video, in this surgery, I've done a clear corneal incision, but if your graft-hose junction is, if you're doing a larger graft, I think you should not have your incision cross the graft-hose junction. So you can resort to making a slightly scleral incision, which is better because you can avoid manipulation at the graft-hose junction. In terms of, this is a soft cataract, so we didn't have to use too much of phaco power. We are able to use most of the aspiration to try and aspirate out the cataract. But if you do have a conventional moderate to hard cataract, you do just like what you would do in a patient with compromised endothelium. You will use all the lower parameters in terms of your flow, in terms of your aspiration and the phaco energy, and you would take time to break the cataract into small pieces and then remove it from the eye. And it's important that you suture your wound at the end of surgery, because these wounds, because of the kind of nature, you cannot pressurize the eye sometimes, and because of the graft-hose junction being very close to your wound, hydration of the wound is also not advisable, because you can sometimes end up creating a DM detachment. So I think best is to place sutures and ensure that your wound is watertight. So in this case, we were able to put the lens, and the patient had a very good visual outcome. The other thing that you need to worry about is endothelial rejection, because it's a surgical trauma that you're creating, and that can sometimes induce inflammation, and your patient whose eye, the graft has been functioning very, very well, can go in for a rejection as well. So some people recommend starting topical steroids prior to surgery. So if you have a patient several years down the lane following keratoplasty, and patient is maybe using steroids every alternate day or not even on softer steroids, you can consider starting a conventional full-strength steroids several days or a week prior to the cataract surgery, so that and continue it post-operatively for the next few months. The other thing you need to monitor is the intraocular pressure. And for me, in post-keratoplasty eyes, we avoid using topical NSAIDs unless the patient has that specific risk for developing CME, because topical NSAIDs are not very friendly to the epithelium, and you don't want your surface, which is already slightly, neuropathic, you don't want the surface to break down on the patient to develop a epithelial defect. So basically, in conclusion, cataract surgery in post-keratoplasty eyes, it requires some amount of pre-op planning. Stable topography is essential for IOL power calculation, and if the patient has preoperative astigmatism, I think before you embark on a cataract surgery, try and see what options you have to try and manage the astigmatism, especially the irregular astigmatism. Make it regular, because in an irregular astigmatism, even if you put a toric IOL, the patient's quality of vision is not going to be very great. Modification, surgical steps, and perioperative care, both starting pre-op and post-op, can ensure survival of the corneal graft. And always remember that additional procedures may be necessary to refine the refractive outcome. So this needs to be conveyed to the patient. Often we have done surgery, and later on we find that there are some residual errors. So you can either look at doing a laser-based procedure on the cornea, or if the cornea does not allow a laser-based procedure, you can think about putting a piggyback IOL. And the one important thing which I have not mentioned here is that when you do a cataract surgery in post-keratoplasty eyes, always discuss the possibility of the graft failing and the patient requiring a endothelial keratoplasty later on, because this is something you cannot predict, because a lot of these low cell counts, despite the best of your effort, It's possible that after the cataract surgery, the graft may, it may not happen immediately after surgery, but gradually down the lane, the graft may fail because the cell counts have further decreased. So this is something that if you discuss with the patient preoperatively, the patient will be more amenable later on for a second procedure. Otherwise, if you have not discussed this, you'll always find fault that when you've done the cataract surgery, you have damaged the graft, which was functioning very fine for a long time. Thank you. Thank you for a patient hearing.
Thank you, Dr. Rajesh. Any questions? May I have the lights, please?